Welcome, everyone, to our event. We have a really impressive panel today. I'm going to allow Ovid to provide some opening remarks, and then I'll go through our agenda.
Hello, my name is Ovid Amitai, and I serve as President and CEO of SolveME. Welcome to members of the press, and for all of you who are joining us today. You may ask yourself, why did we launch this project to estimate the financial burden of long COVID and its impact on the labor market? As we enter the third year of the COVID-19 pandemic, we co-authored this white paper to provide a lead-in analysis of the looming public health crisis of long COVID. Based on our previous experience, we recognize how important it is to quantify the burden of invisible chronic diseases so they are not ignored, as myalgic encephalomyelitis, also known as chronic fatigue syndrome, was for decades. This report should not be viewed as a final product, but rather as an open invitation for others to use new and additional data and perspectives to refine the analysis and better understand the impact of long COVID, so that the true scope of this mass disabling event can be addressed and lead to better policies and improved outcomes. Now it's my pleasure to introduce our moderator for the webinar today, Megan Green. Megan is a senior fellow at the Center for Business and Government at the Harvard Kennedy School, where she teaches and is writing a book on inequality. She's also the global chief economist at Kroll Institute and serves as a senior fellow of international economics at the Chatham House in London, and a senior advisor to the OECD. She writes a regular column in the Financial Times on global macroeconomics. Megan, the floor is yours.
Thank you so much, Ovid. As I mentioned, we have a really impressive panel today. I'm just going to give you the agenda before we hear some remarks and then have a bit of a discussion about it. First up, we'll have David Kotok. David is the chairman and chief investment officer at Cumberland Advisors. And he's going to discuss the big picture for why we should all care about long COVID. After that, we'll have Ovid again. Ovid is the current president and CEO of SolveME, and he's going to talk about the important work of the Solve Long COVID initiative. Following Ovid, we'll hear from Melissa Smallwood. She's a graduate student attending Arizona State University School for the Future of Innovation in Society, and she's a co-author of the white paper. Melissa's going to give us an overview of the methods that were used in the white paper, and she'll be followed by Philippa Dunn. Philippa is a project manager at Adwat Data and Insight and co-author of the white paper. She'll cover the labor market impacts as it relates to long COVID. As an economist, I'm really interested in hearing some of that insight. And then last but definitely not least, we'll have Emily Taylor. Emily is the vice president of advocacy and engagement for SolveME, and she's also a white paper co-author. She'll discuss the policy recommendations related to long COVID and give an overview of the white paper conclusions. I mentioned that we're going to have a discussion after we hear from each of the panelists. I'm really hoping that you'll provide some questions. You can put your questions in the Q&A box throughout the event. If you're a member of the media, we'll take your questions first. You just have to identify yourself as part of your question when you submit it in the Q&A. Or if you want to arrange for an interview with one of the panelists following the event, you can let us know by messaging Carmen Craiglow in the private chat function, or you can email the contact on the press release. If we don't get to everyone's questions today, we can follow up after the event. So thanks for joining us again, and let's kick it off by hearing from David.
Thank you very much, Megan. It's always a pleasure to see you and all the work we do together at the Global Interdependence Center. Being involved in the long COVID initiative with the Global Interdependence Center and Solve from its beginning has been an eye-opening thing for me. I don't want to spend a lot of time on the labor force with Philippa on this panel, only to say in a big picture view, if we think about the GAO study that said somewhere between 7 million and 23 million Americans are victims of partial, temporary, or permanent disability. And we say something like 30% of those folks are in the labor force. And while we think about that impact of disabled people, we also have to remember that they have caregivers, and the caregivers function not only with the victims of long COVID who are in the labor force, but how about those who are under 16 or over 65? I know in the work I did in the research for my book, I've interviewed here in Florida long COVID victims in the labor force and out of them, and interviewed and researched a number of businesses. And we find that in Florida, Emily was kind enough to help me when I had a presentation, so I got a sneak preview of this paper. There's probably 1.5 million long COVID victims in the state of Florida, and about a third of those are seriously ill. So this is a big deal. It's a lot. Ovid just said he talked about visibility. And in my work and remarks about this, what would we do in America if suddenly we had, say, 10 million visible polio victims all at once? We would respond in various ways, but because this is not visible, we don't see it. And so I think visibility, invisibility is a big issue. I think there's another element for our consideration. When you look at the history of pandemic experience in America, you find that the documentation of long post-viral disease disability shows up last in abundance after the Russian flu pandemic of 1889 to 1896. And there are references to it in history, many of them. We don't see so many references after the Spanish flu pandemic. Why? It was a killer. There were some, but not a lot. And so we don't have in our history, recent history, the notion that you can have a mass post-viral disease cohort of people who are disabled. That's kind of new. We are familiar with it. Solve has worked for years on post-viral disease when we think about it in terms of, say, Lyme disease or others. But now we have grown this population by many millions. The takeaway from all this is we're confronting a very large economic shock, a labor force shock. Philippa can talk about it. We have to figure out in this marvelous piece of work, this research work, which has estimated the costs, is trying to narrow that into macroeconomic numbers. So folks like us and you, Megan, and others can say, wait a minute, this is in the billions. This is big. So that's sort of my opening 30,000 foot view. The more I am able to examine the shock, what it means for the medical research community, for treatment, the multiple disciplines in medical science that are now needed to be involved, and the need for attention for long COVID clinics and treatment, the deeper it gets for me to say, this is a huge shock in America. So why don't I stop there and get out of the way for people who have some real data?
All right. Thank you so much for those comments, David. You framed it really nicely. It does seem like long COVID is a big deal. We just have had a hard time quantifying it. I'm just going to throw out a few numbers, which will be repeated throughout this webinar, I'm sure. But the Solve Long COVID Initiative models estimate there are between 22 and 43 million cases of long COVID in the US. 7 to 14 million are expected to result in long-term disability. And the disability caused by long COVID is expected to cost at least $386 billion since the pandemic began through January of this year. So these are astounding numbers that most people haven't really wrapped their heads around. I'd like to turn it over to Oved, who's going to give us some more details on the long COVID initiative.
Thank you, Megan. And I think the main point I would like to make is that this should not have been a surprise to anyone. SOLVE was one of the very first organizations to recognize the emerging threat of long-term debilitating outcomes of COVID-19. And as early as April of 2020, we already called on Congress to have immediate response measures recommending budget appropriation to the NIH for post-viral research. In fact, we championed the House resolution that was already known as the Long Haulers Act and was presented to Congress by Representative Jamie Raskin in 2020. So this was really the early first step in our long COVID initiative. And our work now represents an assembly of new and expanded programs in research, advocacy, and education. They're all geared towards improving outcomes for millions of people suffering from post-infection diseases. And I said that this should not have been a surprise. And the reason I say that is that our work over more than 30 years, both on research and advocacy, and the experience in post-infection diseases, really help us to understand that this outcome is very often the effect of an infection. So that should really not be a surprise. Post-viral diseases are not new at all. So what we're trying to do is take a strategic approach and integrate what we call pre-pandemic and post-pandemic knowledge, and incorporate our community's insights into that. Our work historically in this space has allowed us to create connections and build partnerships with patients, caregivers, researchers, clinicians, government, and industry leaders. And all of those stakeholders are really needed to make the impact on such a big challenge that we're facing. We're also very proud to be co-founders of the Long COVID Alliance, and are very grateful to Karen Bischoff and Hunter Howard for their vision and commitment in co-founding the Alliance with us. Together, we now have more than 700 members in the Alliance, many organizations, individuals, and these include patient advocates, scientists, disease experts, and drug developers. And we're all trying to leverage our collective knowledge and resources to educate policymakers and accelerate research, ultimately to transform our understanding of these post-infection diseases. Our advocacy and leadership were critical to secure the $1.15 billion that were appropriated by Congress to the NIH in December 2020, specifically for long COVID research. And that really enabled the NIH to initiate the RECOVER study of long COVID, which is now underway. On the research side, we expanded our You&Me registry to have over 1,000 participants in a long COVID cohort. And at this point, it's one of the largest longitudinal long COVID and ME/CFS data sets, and it's available to researchers around the world. We also increased the size and scope of our Ramsey Research Grants program, which supports research into ME/CFS, long COVID, and their intersection. For more information on all of those, please look at solvelongcovid.org. Megan, back to you.
Great. Thanks so much for that. In a way, I guess I find it somewhat comforting that you weren't surprised, at least, that we would be stuck with this issue. It certainly came as a surprise to those of us who were non-specialists. But as you point out, there is historical precedent, and it's great that you guys are doing this work to educate the rest of us effectively. Next up, we have Melissa Smallwood. She's going to talk about the methods used behind the white paper. Over to you, Melissa.
So the goal of the white paper that SolveME and the Long COVID Initiative have just put out is to begin to estimate how many people in the United States may be affected by long COVID. In order to calculate this, we need two pieces of information. One, how many people have had COVID-19 and survived? And two, what is the risk of developing long COVID post-infection? Ideally, we would just have those numbers and multiply them. Fortunately, we've been able to get a decent assessment of long COVID risk through research that has been conducted through large community surveys. Studies into this topic have found that prevalence rates for long COVID range from about 10% to over 50%. Some of this variability is due to differences in the sampling population and other methods. But for studies that are looking at a broad non-hospitalized population, the emerging consensus is that about 1/3 of people infected with COVID-19 have at least one lingering symptom 6 months post-infection. And of these people who are experiencing what we call long COVID, about 1/3 of them, or 10% of the general post-COVID population, report symptoms severe enough to interfere with work or activities of daily living, thereby rising to the level of a disability. So for our paper, we're using the baseline metric that 30% of cases will result in some form of long COVID, and 10% of cases will result in what we are calling disabling long COVID. So this brings us to the other piece of information that we need, which is how many living people in the United States have had COVID. This is the million-dollar question because we really do not know how many cases of COVID-19 there have been in the United States. Next slide, please. So using publicly available COVID surveillance data that is released by the CDC, we found two ways to try and answer this question. The first way is through using official case counts that are reported by states, hospitals, and local health authorities up to the CDC. This is the closest thing that we have to an official count of case numbers. And at the very least, it provides a minimum number of cases that we know with certainty have occurred. However, this is also a flawed metric to use when trying to account for cases of long COVID due to the fact that the undercounting of mild and asymptomatic COVID cases has been a known problem since the very beginning of the pandemic. So in order to account for this and to try and get a grasp on some of these unreported cases of COVID-19 that we know are out there, we created a second model that is based off of the CDC's Community Seroprevalence Survey. This is a survey that looks for a specific antibody that is unique to natural infection. It's known as the nucleocapsid antibody. This antibody is looked for in community samples that are conducted across the country, looking at blood samples from randomly sampled volunteers in different communities. And within the survey, the average prevalence of this antibody within community samples for each state is interpreted as the number, or as the percentage of people in the community who have been infected with the SARS-CoV-2 virus. So when you take these two models together, you get a range of estimates on the potential impact of long COVID so far, with the reported case model giving a more conservative estimate and the seroprevalence model giving us a higher but more speculative estimate. Next slide, please. Needless to say, it's not looking good for us. The reported case model estimates that up to January of 2022, there are 22 million Americans impacted by long COVID, or nearly 7% of the population. And of these, 7.3 million, or 2.3% of the population, are experiencing new or worsening disability from long COVID. And that is just for the officially reported cases that we know about. Next slide, please. So when you estimate case numbers based on seroprevalence instead of reported cases, it gets even worse. The seroprevalence model estimates about twice the number of cases of the reported case model, which puts us at 43 million people, or 13.5% of the population, potentially experiencing post-COVID complications, with 14.3 million, or 4.5% of the country, experiencing disability. Next slide. So our next step after calculating these case estimates is to try and put these numbers in perspective by looking at what this means for us economically. Fortunately, the wonderful folks over at the COVID-19 Long Hauler Advocacy Project had previously done some research looking at the individual financial impact of long COVID, with their survey specifically focusing on people who are experiencing the more severe or are on the more severe end of the spectrum for being affected by long COVID. And because of this, are largely no longer able to work or no longer able to work at their full capacity, and are in many cases are suffering dire economic fallout from this. So by combining this pre-existing research with our model looking at disabling long COVID, we created an estimate of the individual financial burden of long COVID through healthcare expenditures and lost income and savings. Please note that these estimates only are looking at the 10% of COVID survivors that are experiencing significant disability from long COVID. This is not getting into the financial consequences of quote unquote milder long COVID that might pop up for people further down the road, or on the ripple effects of this on businesses and communities. Next slide. So using the case numbers from the reported case model, we estimate an individual financial burden of $386 billion so far, up to the end of January of this year. Next slide. And with the seroprevalence model, this estimate jumps to $511 billion just for individuals. I'm going to let our next panelist, Philippa, take it from here on what these numbers mean for the larger labor force.
Yeah, let me just interject with a methodology question before we move on to Philippa, if that's okay, Melissa. There's a question about whether the 10 to 30% still holds with the seroprevalence model. Do all of the people who might have had even mild or asymptomatic COVID still have long COVID? Or does the 10 to 30% only apply to reported cases and maybe reported cases and some people who definitely had COVID but couldn't get tested, et cetera? Does that make sense?
Yeah, let me just read the question.
Okay.
So it is important to note that long COVID can occur from any case of COVID, including mild and asymptomatic cases. Mm-hmm. The majority of long COVID cases are actually from quote unquote mild or asymptomatic non-hospitalized cases, just because this is the majority of COVID cases overall. But yes, the 10 to 30% is being applied to both the reported case and seroprevalence models. There is a modification that we made to account for breakthrough cases in vaccinated individuals that occurred during the Omicron surge. I can get into that in the Q&A. I didn't have it in this part of the presentation because I didn't think there would be time and it might be getting a little into the weeds.
Yeah, okay. Great, thank you. Let's pass it on to Philippa, who's going to talk about some of the labor market implications of all of this. Over to you, Philippa.
Okay, hi everyone. It's really an honor to be here. So as a sort of anecdote, I've covered labor trends for 25 years. I'm somewhat inured to ghastly figures and I check my work often. I have never checked my work as often as I have in the course of this project. The numbers and percentages are stunningly high. And we now know from the Government Accountability Office that they recently came out with similar projections, which confirms that this is indeed what we're facing. So we don't know how many of those individuals affected with long COVID or disabling COVID, I'm really talking more about disabling COVID, were in the workforce prior to diagnosis. But we can put even the low estimate, the 8 million of affected, people in context. Between the onset and the trough of the Great Recession, 8 million people lost their jobs. That was jaw-dropping at the time. In some states, you will see in a model we put together later, the share of, if you think of the number of cases as a share of the labor force, even though they're not strictly translatable, that comes to 6% in the most seriously affected states. And that was the share of people who lost their jobs in the Great Recession. So there's no question that this is a really devastating event. I wanted to take a moment to talk about something a little different, which was early on in the pandemic. Not only were the plight of our essential workers in the press a lot, at one point, Tom Barkin, who runs the Richmond Fed, said and identified his district and the Atlanta district, which is Raphael Bostic's district, as the former Confederacy. He said that gave them a whole different set of problems to deal with. He vowed to dig in to understand better, and he said he might create a different narrative. Long COVID threatens to exacerbate inequality. Infection rates are higher in many of the states that already have elevated disability shares. And in rural and frontier areas where medical care is harder to access, they also have very high rates. Overall COVID infections are higher among more vulnerable populations, and employment was hardest hit there as well. But we do have control over how some of this works out, and this is to echo what everyone's been saying. And devising strategies to ameliorate profound effects sort of gives us an invitation to join Barkin and Bostic in their efforts. There are a lot of acknowledged long-term trends that people have been suggesting for decades we should change. Those include the perverse requirements of our disability system, how we value our care workers, and regional imbalances. So I think that Emily is going to cover most of this, but we need a really all hands on deck approach to keeping people with disabling COVID in the labor force, the ones who are already working. And for the ones who weren't, we need to devise strategies that make it possible for their family members to balance care responsibilities and work responsibilities so that they can stay at the labor force. And I'd also like to point out that since February 2020, there's been a lot of attention on wages among lower paid workers. And since that point, accommodation and food service workers, wages are up 17%. Overall wages are up 12%. And those for home care workers are up only 10%. So they're lagging the trend there, even though they're obviously very important. I also wanted to point out that the BLS projected recently, that over the next 10 years, we're going to need 1.1 million more home health and care workers. And that's 8 times the number of the distant second, which is health managers. All of the 4 biggest projections are in healthcare. And that's a sector that's going, because of demographics, is going to be very hard hit by long COVID. So now, if you could put up the slide. Perfect. There we go. Okay. So this is an attempt to put in context the varying labor force participation rates and the varying infection rates in the individual states. So you'll notice on the labor force participation rate that the percent varies by almost 20 percentage points. Well, more like 15. So, and the disabling long COVID rate runs between 3 and 6%. So we took the burden that was calculated by state in the previous slide set and divided it by the number of people who are either working or looking for work, which is an indicator of how healthy the economy is to me. So by doing that, we were able to calculate a different burden per worker, or I'd say for each member of the population who is engaged with the workforce. And that runs from low 50% of the national average to in the high 130% range. And we did this to provide information for state policymakers so they can sort of see what they're dealing with. And you'll see that Arkansas has a low participation rate, a high infection rate, and a cost share that's 128% of the average of the national average. And the District of Columbia, that has a very high participation rate and also a low infection rate, has a burden that's just 76%. So that's I hope, a very clear picture of the regional disparities. I know that looking at a lot of these numbers and thinking about the personal suffering is really discouraging, but the reason to look at statistics is to try to come up with better outcomes. And I would say, echoing everyone else, we really have our work cut out for us. Thanks.
Great, thanks, Philippa. Last but definitely not least, let's hear from Emily Taylor. She's going to cover policy recommendations related to long COVID and provide an overview of the white paper conclusions.
Thank you so much, Megan. It's a pleasure to be here. I also have slides, if I could get those pulled up as well. I'd like to start with a quote from a colleague of ours and a partner, Lisa McCorkle, which she was recently shared in the Brookings Institute piece. She said, until we have data from a representative sample that accurately capture the extent of the impacts to the labor force, economists and policymakers are likely not going to consider long COVID an economic issue or recognize it for the mass disabling event it is. And I wanted to highlight that because truer words were never spoken. And this data that we've shared is a snapshot. And it's a snapshot taken from a cell phone that looks at all states at the macro level and our country at the macro level. We still desperately need, as Lisa articulated, telephoto lenses and zooming in with professional type camera equipment to really look at these impacts. And hopefully what this paper accomplishes is sharing that snapshot, illuminating that snapshot, so that other folks with those telephoto lenses can come in and really drill into the impacts in specific sectors, specific areas geographically, and specific population demographics. Next slide, please. So a couple of the key conclusions that we really want you to take home with you as you read this paper is that post-infection illness is not new, and that this is a massive problem that cannot be resolved by the market alone. Also, what we've really learned from the experience of post-viral patients is that disability is not an immutable state. You don't remain in a particular state of disability for your entire life. It ebbs and it flows. But disability payments for folks who are fortunate enough to get into the disability system are sort of considered a payment of last resort, only for those who are not able to go back into the labor force. We really want to look to employers that they should look at disabled employees as a bit of an opportunity, accommodate your workers with a post-infection illness to work with them, keeping them out of the disability system and in the labor market. And that is more reflective of the ebb and flow that naturally occurs with disability from these post-viral illnesses that are not immutable, that have good days and bad days, that have workable days and non-workable days. And as Philippa shared, key industries, specifically home care and nursing, must be valued more highly and are absolutely going to be critical, as unfortunately, some of those with disability as a result of long COVID may not be in that ebb and flow space. They may be permanently disabled, and that's going to cause an increase in those sectors. And next slide, please. One item that I think has not been highlighted here, but is highlighted in the paper and must absolutely be paid attention to, is the impact on BIPOC communities, or Black, Indigenous, people of color. That's what BIPOC means. The people, and this is a quote from PBS NewsHour, the people who are likely to suffer the worst brunt of long COVID and the lack of an infrastructure to be able to deal with it are already the poorer and more marginalized communities that were hardest hit by the virus. Our research and our work in this, and especially Philippa's work diving into state disability and state inequality, really demonstrates and reiterates this point that these communities, especially folks in healthcare and nursing that were the frontline fighters, the essential workers, were hit disproportionately hard. And we absolutely need to create a system that cares for all people, but with a special emphasis on those who are disproportionately harmed. Next slide, please. So how can this translate into policy? How can this translate into actionable steps that will help these folks and keep our disabled long haulers out of poverty? First of all, we need to incentivize employers to keep workers on the job through workplace accommodations and vocational support. In the paper, we look at a couple examples from other countries that have revised their disability systems to focus on these areas, and we highlight some of the ways those policies have been beneficial to people with disability. Secondly, we need to reduce barriers for accessing disability, returning to work, and then returning back to disability as needed. As I said before, disability is not an immutable state, and especially with post-viral illness, as the long COVID community is experiencing, it's a variable experience of illness that some days are good and some days are bad. So we need our disability system to reflect that and not force everyone from a square peg into a round hole, but rather have a variable system that allows people to, as their symptoms improve and they return to health, come back to work. And if they crash or if they fall out of that health journey of improvement, don't punish them for it. They need the support to get when they need support, and then the support to get back to work when they can. This really highlights the need for legal assistance and disability supports for individuals navigating these new systems, trying to get in and out of disability as needed. And that should not be a full-time job. So legal assistance, disability supports, case managers, advocates, all of those are critical functions to help long haulers through this system. And last, but again, definitely not least, I want to emphasize again that a special consideration absolutely must be given to communities of color who were disproportionately impacted by the pandemic and thus disproportionately impacted by long COVID. Last slide, please. So with that, I just want to step back and remind folks that this is a urgent public health crisis. These numbers are simply a preliminary snapshot. And I know as time continues and more cases build up and we have more and deeper understanding of how these different biomedical systems are failing, we're still going to need to have our economic and policy and government structures shore up to support this population. So it requires an immediate response. And we're absolutely committed to helping the millions who suffer with the knowledge of post-viral disease that we can bring from over 30 years of research. So with that, I very much look forward to your questions. Happy to assist however we can. And thank you all once again for your attention to this critical issue.
Great. Thank you so much, Emily. We've got some time for a discussion now. Just a reminder, you can submit your questions in the Q&A. And you can, if you're a working member of the press, then please specify that so that we can prioritize your question. We're going to start with a few methodological questions because as an economist, I know that it's always really difficult to measure stuff. And so I wonder first how you guys approach, and this might go to Melissa, but Oved, you might have a contribution as well. How do you know when people are so sick with long COVID that they can't work? Specifically, how do you draw that delineation? And also, as we get new variants of this, how do you update your models? Can we assume that if we get new, more transmissible variants, for example, that you guys will be updating your estimates? Melissa, let's start with you.
Sure. So the first question, how is basically long COVID being so disabling that you can't work defined? In the source paper that we're using for those estimates, that was essentially based on self-assessments. And in the and I think that the COVID long haulers labor force paper gets into this a bit more, but basically many of the people who are unable to work are suffering from conditions such as essentially ME/CFS or POTS post orthostatic tachycardia syndrome, I believe, basically causing to have symptoms like extreme fatigue after mild exertion or the inability to stand for extended periods of time. Basically stuff like that makes it hard for them to conform to the expectations of the standard 9-to-5 workday. And I just want to note, this is especially amplified for people whose jobs require physical in-person work. So I'm thinking, healthcare workers, teachers, retail and food service workers, people who, were more likely to be exposed to COVID in the first place because of having an in-person job with few protections, and being in a job that requires physical exertion, which is a known factor that can exacerbate the post-exertional malaise seen in ME/CFS. So it's really a vicious cycle. And then the second question, how are we going to update this data for emerging new variants, particularly BA2? This is personally one of the things that is keeping me up at night, because one thing that we're seeing, or rather two things that we're seeing with BA2, one, we are completely losing track of testing. The funding for PCR testing for uninsured people is drying up. More people are having to rely on self-administered at-home rapid tests, or just not testing at all and just assuming they have a cold or just toughing it out at home. In either situation, these case numbers are not being reported in the official case counts. And two, there's emerging evidence that BA2 is capable of causing reinfections, including in people who have had BA1. And that is unfortunately one of the major weaknesses of our seroprevalence model, is that it's a binary of have been infected with SARS-CoV-2 or have not been infected with SARS-CoV-2. And there currently isn't, capability within that measurement to assess for reinfections or to assess how many times somebody has been infected. So that is still a real work in progress, but it is a sticky one.
Gosh, that is terrible news. As an economist, I'm not used to not being the gloomiest person in the room, but there we go. Ovid, I don't know if you had anything to add to that.
Yeah, just a quick comment, which is that a lot of what we know about long COVID, and certainly initially the recognition that we're actually seeing this disease, it actually comes from patients. And the very first publication came from the patient-led research collaborative, was published in The Lancet. They really characterized what people are experiencing. And the debilitating symptoms were primarily this fatigue that's really not replenished by sleep, the post-exertional malaise, and brain fog. And brain fog really is a different way of addressing or saying that we have some cognitive dysfunction. And so that also leads to the understanding that even people who are not working in a physically demanding job would still be facing significant challenges. And so in that survey, there was an estimate that 7 months after the infection, about 2/3 of people could not really hold at the same level of employment that they did before. So a lot of the information that we have really is coming from the individuals who are facing that. And obviously we need a better data, but there's quite a bit that we know already. And this is very much in line with what we've seen in other viral diseases in the past. And certainly SARS can give us some estimate. And they're all within this range that we presented today. So I think that the history certainly is telling us that what we see is real. These are probably the real numbers.
Yeah. Okay. Thanks. Philip, I've got a question for you. Those of us who have been studying the jobs data for years at this point recognize that the labor force participation rate has dropped significantly in the US and hasn't actually rebounded, unlike everywhere else in the developed world for the most part. The US faces this uniquely. And I'm just wondering if you can give us a sense of how much of that gap still can be accounted for by long COVID.
It's funny, I was thinking about trying to do that, and I really just didn't feel as if I had the information. But and in fact, that reminds me of one of the points I wanted to make, is that a lot of long COVID will not be caught in the statistics. Because if the people are not unemployed, we don't know why they're dropping out of, we know a lot of people are dropping out of the labor force because of demographics. And we also know that changes in net migration have had a big effect. But what concerns me, and one of the things that keeps me up at night, is that we're just not going to know how many people have fallen out of the labor force because of long COVID. We can calculate percentages, but we don't know their ages.
Yeah.
Then the things we really need. But if I could just take a second to add something to your prior question. One of the things that's really interesting is that one of the drivers of nurse shortages is working conditions. And there's been real progress made with nurses being included in decision making, and that raises retention rates, and they're well known for being problem solvers and highly trusted, as we know from a global interdependence seminar. So I have thought it would be very smart to get nurses also involved in evaluating patients for how able they would be to work, because they clearly would know exactly the condition of the people. So I just wanted to throw that out there.
Yeah, no, thanks. That's interesting. In terms of addressing this, Emily, you spoke about some of the policy recommendations. Do you think that it's up to states to respond to this, given that they have the more granulated details, or is a federal response what's necessary, or what should the balance be?
I think this is, as said before, an all hands on deck situation. It needs to be the federal government, it needs to be state level and county level folks, and it also needs to be the employers and firms themselves that are hiring or dealing with an employee who has long COVID, to keep them with accommodations in the workforce. In fact, there's a list of a partial list of accommodations as some samples for common long COVID symptoms in the paper that I highly encourage employers to take a look at. And I think employers really take their cues from federal and state leadership, and that if the government entities really offered incentives to encourage employers to keep employees in the workplace through partial accommodations or disability accommodations. One item I also want to sing the praises of is vocational training. I was just on the phone with a long hauler patient the other day who was a veteran, a young man who had previously worked in construction, got COVID on the job, and now can't even lift a load of laundry, where before he said he was lifting steel plates and giant pieces of concrete. And now he is using his services at the VA to go back and retrain as a computer programmer so that he can sit and work rather than have to move and stand, because he says he simply physically can't do it anymore. But those services are something he has a support of in the VA, and of course got no support from his employers in terms of any partial time pay or sick leave, anything like that. That's something that's not really common in that industry. So really through the VA, he managed to find help, but not all long haulers are veterans, and not all long haulers have that kind of support. So those are the folks that is kind of an example of real world circumstances where state leaders and federal leaders can offer incentives to employers to work as a partnership to keep those employees on the roster. Secondly, I just want to note there was a question in the chat regarding the approval rate for long COVID patients with disability. We do not have those figures yet. We have been keeping an eye out for them, but I will note that in general, about 2/3 or 66% of disability claims are denied immediately after their first application. That's just common for everybody. It's a very high rate of denial. That rate jumps over 80% when you look at people with post-viral illnesses. And that's something we knew before going into this long COVID trend, because post-viral illnesses are very hard to document. There's still a lot of stigma and disbelief out there. Folks are told it's all in their head and gaslit by medical providers. And then those medical providers fill out forms that dictate your disability outcomes. So medical education just is another area that I really want to highlight as a critical need. And that's something that state leaders and federal leaders can really take the initiative on, because medical education, getting those frontline health providers educated about what's really going on with these patients, how they can be a resource to help them through disability, that's a critical piece of the puzzle.
Yeah, great, thank you. David, I've got a question for you. Do you think that the public health guidance that we're facing right now has taken into account the impact of long COVID? And if not, how should it be updated?
The question is wonderful. And sadly, the answer is guidance has been poor, in my opinion. Some people may disagree. So during the evolution of this pandemic, the mixing and inconsistency of information, unfortunately, has characterized the last couple of years. And those of us in the economics area who write about it, as you do, as I do, others, we see this constant mixed message. And then we have a second disruptive element, which is this insidious, dangerous disinformation. And the combination of the two is, in my opinion, requiring much more clarity than we ever thought we would need in addressing shocks and circumstances like the present one. A good example might be the statistics that are embedded in this report. And Emily provided me with it for a seminar I had to do a week or two ago here in Florida. And maybe Emily can chime in with the statistics. The difference between a fully vaccinated person and the probabilities of serious long COVID versus an unvaccinated, an anti-vax person who gets COVID and a year later starts to evidence long COVID symptoms. And what I remember from the statistics is vaccination rates, which are evidenced by differences in hospitalizations and deaths, because we can easily count them. But if you're unvaccinated, you've doubled the chances of being a long COVID victim a year later. And that's a message. That message isn't even conveyed. It gets buried if you try to raise it. So how to achieve a cohesive meeting is so important. And let's only hope we can get to it and clarify it.
Great. Thanks. Emily, did you have something to add to that, or?
David said it incredibly well. I think the only thing I have to add is when it comes to the vaccination rates, there's been some really interesting studies about specifically long COVID prevention out of Israel that show exactly as David said, that the rates of long COVID are halved by individuals who are vaccine boosted as opposed to unvaccinated individuals. And there is some early evidence that is still being explored about whether getting vaxxed actually helps or hurts your long COVID symptoms. It's some early evidence shows that people who get vaccinated while having long COVID show some temporary improvement as a result of getting vaccinated. But we also know for those who had post-viral illnesses before before the pandemic that the vaccine can cause some flare-ups for those folks as well. So it really is one of those situations where when I speak to patients about, I get lots of questions on this issue. I always tell them, talk to your individual health provider. It depends on your individual health history. If you have a history of responding badly to vaccines, that's something that absolutely needs to be considered and weighed against the risk of being unvaccinated and all of the potential harm that can cause. So it really is up to folks to talk to your individual medical provider and work out what's best for your personal medical history, your risk, how far you are out in the public, and if you're getting exposed frequently or not exposed at all. Those are all critical factors to consider. So that would be my takeaway, is that for people who are already experiencing long COVID or are a previous post-viral disease patient, speak to your medical provider and find out what's right for you. But getting vaxxed is shown to truly reduce the rates of long COVID among people who do get infected.
Great, thank you. Emily, in your answers, oh, sorry, go ahead, Melissa, you've got a contribution.
Yeah, I just wanted to add in that the Israel data that Emily referenced is included in our modified model that we use to look at breakthrough infections. And so far, it's predicting about a 66% risk reduction of developing long COVID between unvaccinated and fully vaccinated cases.
Great, thank you. We talked earlier about how difficult it is to be approved by insurance providers if you've got a long-term disability like this. And there's a question about the dearth of objective tests to define long COVID. I'm wondering, we've identified that as a problem already. I wonder, is it on the table that we'll have biomarkers or tests anytime soon? Could that improve your research? Is that a hope or a pipe dream?
I'm happy to jump in on that one. Yes,
Okay.
yes, and absolutely. When you asked me earlier about the ways that the federal government and state governments can really make an impact, they are the primary drivers of research in this country. The NIH, the CDC, we fund more research out of federal and state programs here than most other countries do, and that is where the government entities can make a huge impact by funding research. I just wanted to note that there was already $1 billion allocated to the NIH, which is being spent to investigate long COVID, and that is doing some stellar work. But it definitely is in the basic science, or that translational science area, is still limited and missing. So this is where I really want to highlight the need for public-private partnerships, drug companies that are developing drugs that had previously been looked at for ME/CFS or post-orthostatic tachycardia syndrome or other forms of dysautonomia and other forms of post-viral illness. Those are not really being explored as long COVID treatments in the expedited way that I think we would like to see. And our government partners can be the ones to really start expediting that kind of research, that translational research, looking at where we already had a head start in these areas as a result of ME/CFS and other post-infectious illnesses, and then take that and run with it for long COVID. And that's, I think, if I could point to one area that I'd really like to see our government partners invest more heavily in, it would be that translational research category. And then also, as I mentioned, bringing it back to the labor market, to what we were talking about in this specific paper, the medical education components and revising our disability system to reflect the more realities of what it is to be a long COVID patient. With a tip of the hat, because I know that HHS and President Biden recently did some temporary regulations and some guidance there that is starting to kind of stem the flow of the tide of the long COVID folks who need the support. But there are still so many people who are falling through the cracks. And just to the point of that, the question from the audience about the lack of biomarkers, that I think is critical, and that sort of dovetails or interconnects so closely with the disability issue, because the way our disability system is set up, you have to prove your disability in a medical capacity, and it is that immutable state, that kind of winner takes all. You're either entirely disabled or you can work, and there's no in between. What if you're partially disabled? What if you can work 1 day a week or 2 days a week, and then you're punished for that as somebody who's disabled for going back to the workplace? So again, there's a lot of opportunities for our systems to just be more realistic and reflect the reality of these patients' experiences, and translational research is a great way to do that. And Melissa, sorry, I'll jump over to you.
Yeah, I just wanted to add 2 things. One, microclots. Those are emerging as a very likely biomarker, and we really need more research in that direction. 2, I also wanted to comment that trying to find a biomarker singular might be kind of a double-edged sword, because at this point, we're not entirely sure that everything under the umbrella of long COVID, or PASC, as it's referred to in the medical literature, is caused by a singular thing. For all we know, there could be multiple paths that are causing this long-term illness. And if we define it using one biomarker, that does run the risk of only capturing and validating a certain subcategory of patients, and leaving anybody else who is suffering from symptoms but doesn't have that specific biomarker kind of out in the cold.
Great. Thank you. Listen, we are out of time. We're perfectly on time. That was my only job, so I'll consider that a success. I want to thank all of our panelists. I also want to thank the audience for all of your great questions and engagement. And I wanted to let you know, if you want more information about the Long COVID Initiative, or if you want to contact a member of the Long COVID Initiative team, you can do so by going to solvelongcovid.org. So solvelongcovid.org. Thank you so much for joining, and I hope you guys have a great day. Thanks a lot.